Thank you very much to the speakers. Really great examples of innovation in care areas where you really needed to optimize and upskill the people who were available. Terrific. We have Dr. Karen Bullock and Dr. Betty Farrell have rejoined us for this panel. Thank you. It's great to have you here. So I'd like to invite each of you to make some comments if you want to reflect on anything that you heard or tell us about your experience in this area. Dr. Bullock, do you want to go first?
Well, I appreciate hearing the interdisciplinary perspective that each person shared. And as I think about social work as a specific discipline and how we are a part of the teams contributing in very meaningful ways, it really was refreshing to hear that social work has been validated and affirmed in teams. I was talking earlier with my colleague Judy Perez, who isn't here now, and we were talking about how for so many years we were trying to earn a seat at the table and getting people to understand what it is that we do and how social workers are effective contributors to teams. And so what I will say is I'm feeling really appreciated as a social worker just to hear the integration of our skills and knowledge in this work. So thank you to each of you.
I would just add two comments. One is, I think, in discussing these different educational approaches, that often it's a combination of each of these things that's needed. And I think about in ELNIC, we get a lot of calls now from hospice programs around the country who say they're like a rural hospice program. They haven't ever taken children, but now with the growing attention to, the opportunities, their hospice programs are being asked to take children. They don't feel like they can hire a pediatric person because they may not always have children or enough of a caseload. And so there's this big need to, train the existing staff. And so, we can share the ELNIC pediatric curriculum, but they still need to go to, a children's hospital that really has an established program because they need to have the clinical experience and they need to see it. And then they need to have pediatric expertise available by telemedicine so that they can have that support when they take on a child. So I think it's a combination of approaches. And then going back to the workforce issue, and Karen, and then, James, you raised some really interesting points earlier about, there's a lot of duplication of effort, and in many cases we have the wrong person on the team, doing the work. So when we revised the NCP guidelines last year, there's a huge new emphasis on the role of the social worker. And so there's a lot of content about how we really should be relying on our social workers for mental health assessments, for much of the psychosocial support, given that we don't have psychiatrists, always available, and leading family meetings. There's so many things. And so I do think all of us in the field of palliative care need to rethink, what is the distribution of work? It's not just a matter of give us more people, but who's doing what? And then also, in this edition of the National Palliative Care Guidelines, we had, I think, 18 organizations at the table. And so, for example, the physician's assistant community has come forward to say, we really want to be a part of palliative care. They are in the process of, investigating the possibility of specialty certification. I know I was recently asked to contribute they're creating an Oxford textbook for physicians' assistants in palliative care. And so, again, we need to have big, wide open arms because there are so many people at all levels of training and education that can help us do this work. And when we truly give social workers the opportunity to practice at their full potential, and when we invite new people to the table who haven't been there, that's the day that our patients in all areas will be much better served.
And if I may add one addition, thank you very much, to encourage teams to consider the fact that social workers are uniquely trained in the area of cultural competence in these areas around psychosocial assessments and much of the work that we do. And although we haven't spent a lot of time talking about cultural competence today, it is important to think about who on your team, as we heard earlier, perhaps it's not this team member, but another team member who has expertise in this area that can go that extra step to be inclusive of populations that are less likely to be utilizing the gold standard of care.
I also was struck by Sister DeMaria and Dr. Krestek. You were talking about working in underfunded environments with complicated patients as well as complicated geographies that you're trying to manage. Could you elaborate on sort of what does it take to work with the existing workforce, cross-train in one case, or work with the existing workforce to really develop the competencies and the capabilities that you need to support a program?
I think the most important thing is the education piece, is to understand that it's not, first of all, it has to go from the top down, and everybody has to have the education on what palliative care is, and so that is enculturated throughout the home that you have your residents in. If you don't have the education, the doctors can come in, everyone else can come in and do what they need to do, but then if we're not supported by the rest of the staff, then you can run into some really difficult problems. I also think the families, we can't forget the families, they need the education as well. So and education will help bring, hopefully, trained people who will then be able to help and mentor others coming.
When we started our program in Fairview, we were cross-training adult clinicians to provide care to pediatric patients. And there was a lot of resistance to it. There were, you go in meetings and people be sitting like this and say, "Are you going to make me see children?" And it's like, no, I'm not going to make you see that. But to really play to their strength and say, why did you come into hospice or palliative care in the first place? And to listen to their fears. And so in the cross-training of the clinicians to educate them, the rural ones as well as the urban ones, and then to provide a network of support. So as Betty mentioned, to have a pediatric palliative care team, either in a children's hospital or somewhere that has a 24/7 call availability. So if a rural nurse goes out to see a pediatric patient at 2 a.m. and can't figure out what to do with the lorazepam, she has a resource to call that she or he isn't in a isolated place. So you need that central place of support with kind of a spoke support as a bicycle wheel, and then just-in-time training. So when Friday afternoon comes up and, oh my gosh, we're getting a pediatric patient, like in the case of Nevaeh, that there is someone that can walk you through it either by telemedicine or over the phone, and then to do those virtual visits together.
And Dr. Youngworth, you talked about the structure of a team really being a factor that contributes to resilience. That in and of itself seems to build resilience. Could you elaborate on that? And did you see, what have you seen or do you think you'll see with the telemedicine approach? Will you have the same team cohesion? Do you think there will be challenges there?
This is more of a theory of what can help to improve just wellness and healthcare in general, and especially for palliative care teams. And I think what we've observed, and know that this is highly anecdotal, is that when teams are able to work together and you have different disciplines supporting each other, and you're absorbing all the different kind of conflict and trauma and suffering with other people that you are actually there physically with, it's a whole different thing than if you're doing it by yourself. I think that impact on the provider can turn into something that is more of a positive experience as opposed to something that really just begins to get burdened down over time. And we've seen that in the hospital setting. We've seen that in the outpatient setting and clinic where we're still building and supporting that interdisciplinary approach. And it's a lot harder for team members to build that resiliency and that wellness. I also work in the community setting with palliative care, where that is primarily as individual providers caring for folks. And just seeing the difference of that, we've been doing some experimentation of having at least maybe two different disciplines going to the new referrals and seeing that difference that it makes, not only in the care that's provided, also in that team approach and how team members are feeling affected in a very positive way. So this is something that it hasn't been, to my knowledge at least, looked at. I think it's something that'd be very interesting to see if that interdisciplinary team approach really can be one of those key factors of improving wellness in healthcare. And something to take in consideration when you're doing telemedicine also, where a lot of that can be, at least right now, with one individual provider, and maybe considerations of having at least two or more disciplines, if possible, being created when you're developing those programs.
Well, I think we can take some questions. I don't know if the people who are standing are stretching or if you have any questions. Over here? No, I don't think so. Okay.
This was a tall person. I like all this discussion about telemedicine. Wanted to share that geriatric workforce enhancement programs, some of them are using telemedicine too to reach rural areas and provide expertise in rural areas as well. But I'm curious if you're looking at expanding to other rural areas in Colorado as well. You said you're looking to go into the community, but are there other hospitals you're looking at too? And are you receiving support from others to make this happen as well? Is the state at all involved in helping expand this effort?
That's a really good question. So we are looking at expanding the program right now. We've actually been approached by another rural community hospital, and we've just put that on pause at the moment until we really feel that we've ironed out a lot of the creases for the program that we are still developing at this time, and has really, I think, made huge advances in this past year, which had a lot to do about the technology, the platform that we were using for telemedicine, which is not necessarily the same platform that you can use in other settings. And so in the meanwhile, I think one of the things that had come up was a new funding mechanism. I shouldn't say it's new, it's more new to us realizing that it's there, which is the upper payment limit, or UPL, through Medicaid program, and that the mountain areas tend to have a very large Medicaid population up there. And so we are planning on applying for a UPL-funded program to extend the telemedicine program into the rural communities. And there are so many communities that you can cover with that one program as one way that we can do that, and that will automatically then connect us with the other hospitals that are in the mountainous regions there. So this is our most recent thoughts and ideas for the next steps, and I guess you can say that would be maybe the state through the UPL funding mechanism.
If I may add a comment, I'd just like to say that Dr. Youngsource is being very modest, and I say this through the lens of a table that I do sit at, which is the Circle of Life Award, and the University of Colorado Health Center is the most recent recipient of that award, and I was a member of the site team that went out to do the visit, and we get a number of applications, I'm so sure you all know, of the award, and what they're doing at the University of Colorado is exceptional. It is comprehensive. I mean, they had a level of integration across not just the city, but the state that we didn't see in any of the other applicants. So I would be remiss if I did not just acknowledge that they're amazing. It's exceptional.
Thank you, Karen, very much.
Thank you for adding that. I really appreciate that. Yes, did you have a question?
It actually was just a follow-up comment on the telehealth discussion, not to get down in the weeds in this one thing, but I do think it's a great example of how we expand the workforce. And one of the things that's limited uptake of telehealth and Medicare is that the rules around getting paid for it are currently quite restrictive, in that the patient has to live in a shortage area. The biggest problem is they cannot be in their own home, that they actually have to go to a clinic site or a hospital, which kind of defeats the purpose because our patients don't want to leave home. The places where we're seeing that kind of get uptake is in the emerging value-based payment space, right? So when folks become accountable for the total care, both the quality and patient experience, but also the cost, this starts to make a lot of sense, not just in rural areas, but even in dense urban areas or in areas where you simply need to extend the expertise. Dana Lustbader and her team with ProHealth, who work in Long Island, so quite a dense population, are in a shared savings program where they've really highly leveraged this with clinicians in the home, sometimes RNs, often trained medical assistants connecting back to physicians and advanced practice nurses in the office, and it works really well. So keep your eye on this space. You're a pioneer out in the mountains, but our hope is that we see this model begin to disseminate across the country.
If I could just add a comment, I think going back to the workforce issue, that most palliative care teams that I know of around the country are so incredibly overwhelmed to just manage their own work in their own institution, that I think we need to be cautious about to what extent do most palliative care programs have the capacity to expand and take on telehealth. But instead, an important issue is there's a lot of telehealth happening across the country that has been in place for many years. Primary care providers, other specialist training, nurse practitioners, PAs, et cetera. And so to me, there's a huge opportunity to say, can we as a palliative care community of specialists, what are the opportunities for us to take palliative care to all of the existing telehealth networks? Because that same, advanced practice nurse or social worker who's doing, telehealth, shouldn't they be the person, carrying palliative care forward as well?
Good point. Yes, Brenda.
So I'm going to continue the telehealth conversation. I heard a speaker at a different conference a number of months ago who said the most important policy that we in healthcare could be advocating for on the Hill is to have a national plan for 5G across the country. That it would probably need to be a public-private partnership, but gave the example of that this is underway in Rwanda, of a public-private partnership to have 5G throughout Rwanda. And her challenge to the audience was, we go up to the Hill with, our agendas and all, but from elevating up to what will make the difference in this country in terms of access, and we're hearing, in terms of that, this is an important thing to advocate for. So it was kind of an interesting take on healthcare. She was not a healthcare individual. The second comment I wanted to make, though, and particularly as I listened to, Sister, your experience of what you're doing, it's good care. And I listened all day long, and if it has taken, and Bryn showed not labeling the document palliative, if it's taken to label it palliative, to be a catalyst Eventually, maybe the future is there's the expertise, but it really becomes this is good care. This is what we all are about. And so maybe that at some point in the future, we won't worry about the trough that we saw in Dr. Kamal's diagram, where we saw that trough of the physicians in palliative care, because we will have elevated everything. Wouldn't that be great?
Pam, did you have a question?
Thank you, Joanne, and thank you all. I have so enjoyed every panel, and I really like the practicality of yours and the hopefulness. I wanted to share with you one program that's led by Dr. Megan Weaver, also a palliative care program that's received your award. Thank you for that. She has just led a program in pediatrics that does exactly what Betty described, of bringing in the hospice workers to the hospital to work with palliative care teams, including the nurses on the floors, taking care of the patients who are now going to go home to a very rural state. And I wanted to share with you two research outcomes of the first pilot, which had 15 families. So now the hospital-based palliative care team for pediatrics is being beamed into the home, where the hospice workers are waiting for them with also the family members. So there's an official visit, but also a handoff. The child theme from the qualitative data was happiness that the team back at the hospital had not forgotten them. So great pleasure in not being forgotten. The family theme was they always felt separated from their friends and family and felt that they did not understand what they were going through. And the only ones who understood were the people back at the hospital. But the telemedicine handoff visit allowed them to invite in a minimum of 2 other people, usually between 2 and 7 friends and family, who now could become part of their transition to home. So not so alone in thinking that only the people back at the hospital understood. So many benefits from the child perspective and the family perspective of what you're creating and Dr. Weaver has created. So thank you.
Okay, well, I don't see any other folks lined up for questions. So let me just ask our panelists and our speakers if you have any final words that you'd like to say, and then we'll wrap. No? Okay, well, thank you all very much.